Good afternoon, and welcome to the National Health Council's briefing on leveraging patient insights to optimize telemedicine policy. I'm Randy Ruda, Chief Executive Officer for the National Health Council. And since the onset of the pandemic some 18 months ago, we have all been challenged to support patients and the array of healthcare ecosystem stakeholders around them. By necessity, we have been agile and evolving, collectively looking for silver linings and lessons learned in the midst of disease, difficulty, and disruption. Now, patients and providers were called on to think creatively about how we use technology to seek and provide healthcare. The learnings from this period are already improving pathways for improving care to people with chronic conditions and disabilities in the settings of their choosing. Our focus today is on telemedicine and results of focus groups that the National Health Council held with patient organizations this past spring, as well as telehealth perspective of a healthcare provider, and most importantly, the views of a person who has benefited directly from the use of telehealth. Finally, we'll discuss how Congress can make meaningful and equitable telehealth a permanent option for patients. And throughout this event, we will hear about the benefits of telehealth that it can provide, but also why we need to be thoughtful in how we structure telehealth options to maintain patient choice, focus on outcomes that matter to patients, and ensure that we do not further perpetuate health disparities. Following today's presentation, we would welcome your input. Ask questions of our speakers. Please post them to the Q&A chat box, and we'll do our best to get to them. Now note that we are recording today's presentation and that this recording will be posted to our website. Also, this session is open to the press. So to begin, I'm very pleased to introduce Crozer Connor, who's a senior legislative assistant for Congressman Mike Thompson, who is from the 5th District of California. Mr. Thompson chairs the Congressional Telehealth Caucus as well. His portfolio includes tax, healthcare, financial services, and other associated issues. In that capacity, Crozer has overseen the process of crafting Connect Act 2.0 and additional telehealth legislation for the 117th Congress, working closely with his bipartisan colleagues on the Telehealth Caucus and in the U.S. Senate. I'm very pleased today to introduce you to Crozer. Thank you so much, Crozer, for the work you do and for being with us today.
You bet. I'm happy to be here. Thanks for having me. I want to apologize first. Despite what it says at the bottom of my screen, I am not Congressman Mike Thompson. Mike was looking forward to being here today, but he had something come up this morning and is unable to join. We'll look forward to getting him on the next event. And I thought what I would do is just give you a brief overview of where telehealth has gone over the last 18 months, and then where we see things moving sort of post-COVID. I think as Randy pointed out, telehealth has been one of the very few silver linings of the last 18 months. And it's something that my boss and I are very proud of, given the role that Mike played in expanding telehealth in Medicare at the start of the pandemic. Way back, I want to say it was March of last year, Congress signed, or the president signed into law, legislation of Mike's that allowed HHS to expand telehealth during the pandemic. That was actually language that we wrote thinking about wildfires, not pandemics. But when the pandemic struck, it was something we took to leadership and was quickly signed into law. The flexibilities on telehealth and Medicare, I think many of you know, will go away when the public health emergency comes to an end. And we are working very hard with our colleagues on the Telehealth Caucus, our colleagues on the Ways and Means Committee, the Energy and Commerce Committee, and our colleagues in the Senate to make permanent as much of the telehealth expansion that we've seen as possible. Some of you may have seen last Friday, I believe, the Centers for Medicare and Medicaid Services proposed a rule that would allow for the continued use of telehealth in Medicare through the end of 2023. We're still working to understand exactly the scope of services that will be covered by that 2-year extension, but we're very pleased that the administration and Secretary Becerra seem to have taken a very open-minded and balanced approach to ensuring that this access doesn't disappear, that there is a glide path, sort of an off-ramp, so that patients and providers don't suddenly wake up one day and no longer have the option of telehealth care. As pleased as we are with a 2-year extension, we certainly will not let the perfect be the enemy of the good. We do think there are a number of telehealth provisions that should be made permanent based on what we've seen over the last 18 months. And so we have introduced bipartisan and bicameral legislation to do just that. We're particularly proud that the legislation has, at this point, I want to say 61 or 62 senators signed on as co-authors. We're up around the same number in the House, and we're pursuing a Congressional Budget Office score of that legislation, which I'll get to in a minute. But among other provisions, the legislation would allow HHS to expand telehealth at the Secretary's discretion moving forward. I see there's a question in the chat about the legislation number. It is HR 2903. I don't know off the top of my head what the number in the Senate is, but the House bill is 2903. The legislation would allow HHS to expand telehealth services in Medicare if the Secretary of HHS determines that it will not adversely impact the quality of care. The legislation would also permanently eliminate geographic restrictions on originating sites, which are rules in place that stipulate that generally patients need to be in certain areas or at certain locations in order to visit a provider remotely. We would also permanently enable Medicare beneficiaries to receive telehealth services at their home, as well as make permanent telehealth access at federally qualified health centers, rural health clinics, Indian health service facilities, and a number of other locations. One provision that we think is particularly important and somewhat helpfully, we don't think is very expensive, that there's also language in there that would allow HHS to expand telehealth during future disasters the way they did during COVID. The reality is that, God forbid we have another pandemic, but whether it's a disease or a natural disaster or any other circumstance, we don't believe HHS should have to come back to Congress on sort of an ad hoc basis every time in order to expand telehealth during emergencies. And so we're going to be pushing very hard. We are pushing very hard for as much of that legislation as possible to be signed into law. We are very pleased that Congressman Doggett from Texas, who chairs the Health Subcommittee on Ways and Means and is therefore a very important player in the healthcare space, he is working on his own telehealth legislation that will incorporate significant parts of the CONNECT Act. And we look forward to working with him and the rest of our colleagues to advance those provisions to the president's desk this Congress. I think the last thing I'll run through is some of the challenges that we face and some of the things that organizations like yours can do to support us in this work. Obviously, there's a procedural challenge when it comes to cost. I know this can be a little bit confusing to outside advocates, given the amount of money Congress is spending, over the last 18 months and prospectively. But the Congressional Budget Office has historically taken a very conservative view of telehealth, in that they believe when Medicare beneficiaries have access to telehealth services, they will see their providers more. And while as Democrats, Mike tends to think that healthcare is near the top of the list of things the government should spend money on, it does produce some very high numbers. The scores get real big real quick, and we're talking about potentially tens of billions of dollars in spending. And in most contexts, that will need to be offset. And so I think that I don't know that there's an easy way around that procedural obstacle. But one thing that groups like yours can do is provide data. And this applies to a number of the obstacles we face, but to the extent that you can demonstrate that telehealth access does not drive up utilization unnecessarily, that would be really helpful. I would be interested in seeing that. I know CBO and MedPAC and the committee would all be interested in seeing that. That's been a long-standing obstacle to telehealth legislation in Medicare. I would also say that we are in the process of building a data-driven case that telehealth services should be reimbursed at the same rate as in-person care. I think we know at this point there are certain areas of healthcare. Mental health is a key example where we have the data to show that patients who visit their provider remotely will have similar outcomes to patients who see their providers in person. But when we talk about Medicare permanent telehealth access, we're talking about an enormous range of healthcare specialties, and it is important both from a getting the bill passed perspective and from a policy perspective that we can show that this is fundamentally good for patients, that the outcomes are good for patients, and that we should pay for these services the same way we would for in-person care. The last obstacle that comes up that I would highlight is what I would call healthcare disparities. Both rural versus urban, low income versus higher income, racial disparities. We think telehealth has the capacity to improve a lot of these disparities, but it's important that we do this right. The reality is that if, for instance, if you don't have broadband, expansion of telehealth really doesn't do much for you. And if you're maybe you're older and you're not super comfortable with smartphones or iPads or the technology you need, maybe you're in a low income community and you can't afford the technology, all of these things will be gaps in access that need to be closed. We want to make sure telehealth is not another division between the haves and the have-nots. We want to use telehealth to close those gaps, expand access, and ultimately drive down costs. So I may have gone over my allotted speaking time, but I'm happy to be here. I've got about 20 more minutes that I can be with you, and I'm happy to answer any questions that you may have.
Great, thank you so much, Crozer. If folks have questions for Crozer, if they can put them in the Q&A, we are going to continue moving along in the agenda, but certainly we can answer questions in the chat as we have our next speakers coming up. So I'm Eric Asha. I'm the Vice President of Policy and Government Affairs at the National Health Council. Thank you all for being here today. And thank you very much, Crozer, for kind of filling in at the last minute for the congressman. Appreciate you doing that, and certainly appreciate all the work that you and your boss do to really elevate this very important topic. So gonna introduce our speakers, and then as Randy mentioned earlier, we will do Q&A at the end. So as we go on throughout the rest of the event, feel free to put those questions in the Q&A box, and we will have folks come on camera at the end to answer them as best as we can. So first up, we are going to have introductory remarks from Sharon Radke from Milton, Vermont. Sharon is going to share her experience using telehealth to manage a rare disease, and also to help her husband as his caregiver manage his conditions as well, and the benefits that we've seen from telehealth. Following Sharon, we will hear from my colleague, Dr. Eleanor Perfetto, who is the NHC's Executive Vice President of Strategic Initiatives, who's going to review the findings of some listening sessions that we did with patient organizations, so the broad range of patient perspectives on what they've seen with telehealth over the past 18 months. After Eleanor, we're going to hear from Dr. Marcus Snow, who is the Assistant Professor of Internal Medicine in the Division of Rheumatology at the University of Nebraska Medical Center. Dr. Snow is going to share his perspectives as a treating clinician, treating people through telehealth both before and during the pandemic. And last but not least, we are joined by Hannah Lynch, who is the Associate Director of Federal Government Affairs at the National Psoriasis Foundation, who's going to walk through some principles that we in the patient community have developed around telehealth policy. And we'll really kind of take what we hear from our previous speakers and show what you as staff or members of Congress can really do to drive forward some of the lessons learned in a policy perspective. So I'm going to now turn it over to Sharon, who's going to be first up to share her experience, and then we will continue on in the event. I'm really looking forward to it. Thank you.
Good afternoon. I'm Sharon Radke, and I live in Milton, Vermont. I moved here 14 years ago to be near my daughter and her family. And in 2015, I was diagnosed with pemphigus vulgaris, which is a blistering skin disease which affects your nose, mouth, throat, and sometimes your skin. Luckily, there was a doctor here in Vermont, a dermatologist, who knew what it was because she had studied at Johns Hopkins University. And she immediately put me on treatments. First, it was prednisone, followed by Cellcept for 5 years, and then rituximab infusions. I had terrible side effects from the prednisone, and I had to use a cane to walk for 6 months, taking the prednisone. But it took 5 years, and I finally reached remission. This disease also has financial consequences as well. I've been an events specialist for 30 years. And once I was faced with pemphigus, I had to step away from that work because it was too rigorous. I also was teaching at Champlain College, and I had to step down from that. And then in addition to that financial loss, when I had the rituximab infusions, I was just stunned at the cost. It was $25,000 per infusion, and I've had 8 infusions. Luckily, my insurance covered that, but if it hadn't, I'd be bankrupt 8 times over. Although my dermatologist is here in Vermont, she is not a blistering disease specialist, and we don't have any here in Vermont. So during the pandemic, I began facing some new issues with the disease, and she suggested that I reach out to the University of Pennsylvania's Blistering Disease Department to see if they could help me. And I was connected to Dr. Corey Simpson, who did all kinds of tests, and he guided and coached me into remission. So I'm very pleased to say I'm in remission right now. He would check in regularly. We would write to each other. I would send questions to him when I was worried about COVID or vaccinations or other issues. But then a couple months ago, he told me that he was taking another position in September. And that's when I asked him if he could refer me to one of his colleagues there. And he said he couldn't because the funding is ending for televisits through the pandemic emergency funding. I'm heartbroken because I just felt that I had such a high amount of care, and I don't know what I'm going to do. I can't, driving 400 miles to Philadelphia for a doctor's appointment is out of the question for me. So I will return to the UVM Medical Center, to their dermatology department, which they're great, but they're not blistering disease specialists. I also want to mention that televisits have helped me and my husband right here in Vermont. During the pandemic, I was able to do physical therapy and also my counseling sessions through televisits. And then my husband, who is being treated for both cancer and Parkinson's disease, he also has used televisits throughout the pandemic. He's met with his oncologist, his primary care doctor, and his neurologist. And even now, I'm not allowed to go to medical appointments with him here in Vermont. So the televisit is the best choice because sometimes he gets muddled because of his Parkinson's disease, and I can be there to answer questions or to assist him in those meetings. So living in a rural area, televisits are a godsend to us. They really are. And for both me and my husband. So I urge you to continue offering them to all Americans. It really makes a difference in our lives, especially in a small place like Vermont.
Thank you very much, Sharon. Really appreciate you being here with us today and sharing your story. Very important to keep this whole conversation grounded in the real experience and benefits that this has provided and challenges that we continue to face. So thank you. Okay, next I'm going to turn it over to Eleanor Perfetto.
Thanks, Eric. So I think we're going to bring the slides up. Thank you. We're going to talk about some insights that we gained from some patient group listening sessions that we had in the last 6 months or so. So thank you very much. Can you move to the next slide? I think you're going to hear some of the same themes that you've heard before. As we go through this, I want to begin by acknowledging the sponsor for the work that we've done over the last 6 months or so, and that's Neurocrine Biosciences. Thank you. Next slide, please. So we set out to learn about the experiences of chronic disease patients with telemedicine, and we had some specific questions in mind. How can telemedicine improve the patient experience? We wanted to learn about those improvements that we might hear from patients. How do patients define a good telemedicine experience? What are patients' concerns about and barriers to telemedicine access? And so we put together 8 30-minute listening sessions with members of the National Health Council, patient organization members. The interviews touched upon 5 domains. They were recorded, they were transcribed, they were qualitatively analyzed by 2 independent researchers, and the data was organized thematically. And I'm going to just review those themes with you right now. Next slide, please. I want to stop to thank the organizations that participated, and you see that they're listed here. Thank you to them for the time that they dedicated to this. Next slide, please. So the first key theme I think that I want to raise here and point out, and it's one that I think we've come to have a lot of discussions about, and this has to do with disparities. We think that with telemedicine, it would be able to help reduce disparities because it would be able to provide broader access to more patients. And I think we have to keep in mind that there's another side to that coin, and that not, as has been mentioned before, not everyone has access to the connectivity that they need. And that can be in terms of having computer literacy, having access to broadband. We hear very often people talk about how there's such a large percentage of people in this country who have smartphones, but we have to remember that having a smartphone does not mean that you have access to a data plan that allows you to use your phone as freely as you might need to in order to have a telemedicine visit. And so not just owning a smartphone doesn't mean you actually have access. And so this is something that, and we heard earlier about the broadband issue, that there's a question about the broadband issue and how do we bring broadband access to everyone. So there are 2 sides to the disparities issue. One is the potential for reducing disparities because of the ease of access, but then the other side of it is also that there are some people who still don't have easy access to telemedicine because of the technology and internet data access issues. Next slide, please. We also learned some things that fell into this next theme, which is that patient preferences should inform the visit mode. And what we mean by that is patients should be able to voice their preference for whether they want an in-person visit or a telemedicine visit. And there are many things that would have an influence on the patient's preference. So for example, the disease characteristics. What we heard about were things like patients might prefer a telemedicine visit because, for example, if they have a compromised immune system, being able to be at home and not in a waiting room, being exposed to other patients, patients who might be ill and that could put that immunocompromised patient at risk, they would feel more comfortable being at home. However, the other issue is that someone may have an illness where they would need to put a body part in front of the camera, and they may feel very uncomfortable about doing that. And so that would mean that they might prefer the in-office visit. And so there are different things that might be considered here that have to do with the actual disease characteristics themselves. Another aspect is mobility. Surely people who have difficulty with mobility would prefer an in-home visit, telemedicine visit, because it would be easier on them and they wouldn't have the difficulty of getting to an office. However, it's not just mobility due to a healthcare issue, it may be a transportation issue. And so that can also help patients considerably if they have transportation issues in being able to get to their in-person visit. Next is geography. We've heard a little bit more about from Sharon about the issues of being in a rural setting and having access to specialists. And this is another theme that we heard, another key point that we heard, that patients were getting access to care providers that they have never been able to get access to before because they're just not geographically located close enough to them to make it a possibility. And then lastly, the need for privacy. So this is not just a need for privacy in terms of the example of having to put a body part in front of a camera, but it's also the need for privacy in terms of privacy at home. So if you're having a telemedicine visit and you're having difficulties at home, you want to talk about some of the difficulties you're experiencing at home or some of the problems that you may be having with other family members or the other people that you reside with, and they're in the next room, a patient may not be able to be comfortable speaking about what's going on with them at home, and they don't have that they don't have a private place where they can have their visit and feel like it's a secure place for them. So these are considerations that should be taken when you're thinking about those preferences for in-home visits, telemedicine visits versus in-office visits. Can we go to the next slide, please? So we also learned through this process that patients would like to have telehealth technology that is designed and tested with a diverse population of patients. So of course, as the National Health Council, we would promote co-development, co-creation of telemedicine and technologies used in telemedicine to be sure that they are the kinds of things that patients want and can use, and tested, but also keeping in mind that there should be diversity in the patients that participate in co-development and in the testing of these technologies. They also want to have a technology that allows a care partner to join. And you heard an example from Sharon about this one. Many of the patients in the groups that we talked to said that this is a desired attribute. Patients really want to be able to have their care partner join with them. We want to see a technology that supports multiple languages. Obviously, this can help with various populations and making sure that everyone is well informed and clearly understands what's going on with their health and the treatments that they're undergoing. And then we'd like to see accessible telemedicine that doesn't rely on computer, but can rely on a telephone. And so with the telephone technology, again, we talked about that not everyone with a telephone has access because of data plans and bandwidth and Wi-Fi access, but it does allow more people access than computer alone. And so we'd like to see something that is accessible via telephone, along with addressing those access issues. Next slide, please. Thank you. We hope that this kind of information is the kind of information that can help with policymaking, and we will continue to collect these kinds of informative insights from our National Health Council members.
Great, thank you, Eleanor. So next up, we're going to hear from Dr. Snow.
Good afternoon. I am Marcus Snow. I am a rheumatologist based out of Omaha, Nebraska. I'm working with the University of Nebraska Medical Center and Nebraska Medicine. So I'm going to give a brief overview of my interpretation of how telehealth has been important. I think that it's important to realize that different specialties have different experiences with telemedicine. So I can't speak for everybody, but I can tell you where I've been through this and on the journey with this. I also, I'm not going to belabor the point, but I think that everything that has been said from a patient standpoint today, I 100% wholeheartedly agree with. I'll try not to take any extra time in that regard, but I will say that patient access regarding whether they are rural how far away they live, whether they live a mile away from the hospital but have to take 2 trains to get there. Telemedicine provides a huge benefit. On top of all that, I think that other access issues that need to be considered too is any patient who had COVID symptoms, we would have a telemedicine visit in our system. And if you think about the spread of flu in previous years and the spread of influenza this past year, I think that you can realize that bringing patients into the clinic who have active symptoms of an infectious illness, certainly when you triage them with the telemedicine visit, can be of benefit on many levels. So my history with telemedicine goes back to the fact that I used to have an outreach clinic, which was 80 miles away from my office. And in Nebraska, Omaha, situated on the eastern part of the state stretches 450 miles east to west. And most of the people live in the eastern half of the state, or eastern third of the state, actually. And so most of the rheumatologists almost exclusively exist on the eastern third of the state. So I have patients who drive 400 miles to see me. And so these visits early on are increasingly important to have in person. But there comes a point where if you hit a status quo where you're doing well, you're on stable therapy, them jumping in a car and driving 8 hours to see me for a 15, 20-minute visit, and then driving home 8 hours can be difficult. So I've found that telemedicine expands access to the rural part of our state, and also access to specialty providers of all kinds. I think that there are many benefits that we have encountered in this regard. So previous to this, I tried to set up a telemedicine clinic at the same location I was going to, and my patients still had to actually physically get into the health center, and they'd have to get a car, or most of them, who, if they have wheelchairs or canes, would have to get access, have someone bring them into the facility where I would do my telemedicine visit. It wasn't as beneficial. I think that the benefit I was hoping for was lost a little bit. And actually, just prior to the pandemic, I shut down the telemedicine aspect of my clinic, and basically was deciding to change course. Then the pandemic hit, and when the pandemic hit, obviously within a couple of weeks, everything changed. We went from seeing 100% of people in clinic to seeing almost everybody via telehealth. And there were certainly a lot of benefits. You could really help patients along. You could triage symptoms. You could physically look at them. You could see their swollen joints. It wasn't as good as an in-person visit, but it was good enough. And a lot of times it was more than good enough. It was just the same as being in person. And so we found it very helpful to get through the pandemic. I think that as things have opened up a little bit, we have changed our course a little bit in this regard. I will tell you that in our institution, psychiatric care is almost 100% telemedicine still. During the pandemic, dermatology had 100% telemedicine visits. And my surgical colleagues, I suspect that if they are allowed to, most of their post-op visits for those living a ways away from our institution will be doing a lot of their post-op visits via telehealth. So I think there have been a ton of benefits in that regard. I think that speaking from a physician, there are some limitations, and I don't think we can ignore the limitations that exist. I think that when I'm seeing someone for the first time, a physical examination is really important. And so while a telemedicine visit could suffice maybe to help the workup along, to really truly diagnose somebody, I need to see them in person. And so we reached a point where all of our follow-up visits were able to be done via telehealth, but with very rare exception, we wanted to keep our new patient visits in person. There are other fields this is not the case. Our ENT surgeons can look at CT scans and they can talk about symptoms, and they may be able to do an evaluation in that regard. So I think that the downside of telehealth, access issues have been touched upon. I think that it can be tough at times. I will never forget a telephone call I had with a patient who was asking me, well, what kind of arthritis do I have? And I had to explain, I need to see you in person. And so I think those are important parts that we need to recognize. But I also think that in the end, telehealth needs to stay. And I think the telehealth to the patient's home or the patient's phone is a huge benefit that I think hopefully we'll be able to continue moving forward. Those are kind of my history. I think that it's important to make sure that the reimbursement is sufficient, because if you need to make it on par with in-person visits. I also think that telehealth telephone only visits need to stay. They are not as good as video visits, but I do think that they add a significant importance. And a lot of folks who are either having a routine follow-up, a telephone visit is fine, where you can actually suffice and you can do a 6-month follow-up in that regard. And so I do think that continuing to allow telephone visits, telephone only visits, not only helps those who have trouble with the technology, don't have the technology, but I also think there are some instances where I think it is beneficial. So I'll kind of leave it at that. I'm happy to entertain any questions moving forward, any questions at the end, should they arise.
Great, thank you very much, Dr. Snow. Really important and informative to hear direct experience on the provider side of it as well. So next up, we are going to have Hannah Lynch, who is from the National Psoriasis Foundation, who's going to talk about all of what we've heard so far in terms of lived experience or things we've heard from the patient groups, and to better understand how some of the things we've touched on probably are more aligned with pushing providers and telehealth service companies to improve the work that they're doing. But certainly there's a lot of it that needs to be addressed through policy and through Congress. So Hannah's going to talk about some of the work that she and our colleagues have done in this area.
Thanks so much, Eric, and the National Health Council for asking me to speak about this topic. I've gotten to do this a few times across, different Zooms during the pandemic, and so happy to be here to talk about, what the patient advocacy community is doing and hearing from our patients and providers as well around this, and what are some areas we would like to see move forward, and how to do that in a way that keeps that expanded patient access, but also has the patients at the heart of those policy decisions. So I think a lot of the comments that have been made, I will say the same thing as Dr. Snow. I echo a lot of the same comments. So these are also things that we've heard from our communities, and those important stories that we hear from folks like Sharon as well helped all of us from different patient advocacy organizations come together and really think through what policy priorities were important to patients as you look at telehealth and what the future of telehealth is going to look like. Often I'll say, with psoriasis, it's not just a skin condition, it's a systemic inflammatory disease that affects sometimes the joints in your body, really causes inflammation throughout the body. And so we see folks that have to visit dermatologists for their psoriasis, but also rheumatologists if they develop psoriatic arthritis. And so I think that is something that's similar for a lot of patients with chronic conditions. You often don't just experience one. Chronic disease patients often live with several comorbid conditions, and therefore they must seek care and treatment from several different specialists and providers, which is one thing that, the expansion of telehealth has really helped with. It's allowed folks to visit those different specialists, especially if they are not located close to where the patient lives. It's made it easier for them to kind of continue that continuity of care and check in with the folks to really treat their chronic condition as a whole, treat the patient as a whole, rather than just one at a time when they've been able to travel or take the time off work to really do that. It's always important to think about, advocating for telehealth services is not just for the patient at the time, but really how they are with their condition overall. And so when we were thinking through that, a group of 35 patient organizations signed on to a set of patient principles to ensure that telehealth services are affordable, accessible, and adequate for patients. I'm going to break it down into the categories and kind of briefly overview them. I know the link to the full patient principles document has been shared with all of you. So if you'd like to look at that further and really see how in depth we got, I encourage you to do so. One of the biggest things as we set out to do these patient principles, it's really about improving access through equitable coverage. This means that patients that are covered not just maybe in Medicare, Medicaid, an ACA plan, an employer plan, all of those, everyone across the spectrum of different health plans would have access to these expanded telehealth services. It's really, telehealth has really become an essential tool to access care during the pandemic and can help improve access to care over the long term. So making sure that it's available for all, regardless of if it's a state or a federally regulated plan, things like that is very, very important for equitable coverage. Improving access through easing technology barriers. I know Dr. Snow touched on this a little bit, Crozer also. Telehealth services should be equitably available through easily usable technologies that are accessible to people with disabilities, with limited English proficiency, and limited technology. We've seen a lot of this. The use of audio only has really upticked during the pandemic. That's really helpful for folks that are in those rural communities or the elderly, and maybe they're accessing their provider. Maybe they don't have several laptops or tablets or smartphones, but they're still being able to check in with their provider in a safe capacity. So the option of audio only communication is especially important as we move forward, and I think it definitely has a place, for those populations and for also folks that may lack internet access. Really at the heart of this, I kind of previewed earlier, but at the heart of these principles is really preserving the patient choice. As Dr. Snow mentioned, sometimes if you're trying to diagnose a new patient, or really there are certain situations that you do need to access your provider in person. But we do feel that it's important that patients have the option and the choice to choose what type of visit works best for them and their condition. Of course, that is medically appropriate, and working with their provider to make that decision. They should have the opportunity and the flexibility to choose whether it would be in person or via telehealth technologies. For NPF, we work with a lot of providers, and we also hear from our patient community. And in both communities, we've heard some are very for, some are very against. So going forward, I think there are some folks that would love to keep in person all the time, but it's definitely situations, and dependent on the person and the individual, that where a telehealth visit makes a lot more sense for them. Around patient choice, there's also things that go into that would affect, what type of visit a patient is choosing to use. That would be their cost sharing obligations, making sure that not, a telehealth service is not got a cost sharing that makes it either easier or harder to access than an in-person visit would for the patient. Provider payment is also important, because obviously that affects whether providers are offering that service to their patients. So we want to make sure that, that parity is fair and equitable. Utilization management by health plans, so not limiting or how many times a patient can utilize those telehealth services. And then of course, network adequacy. So making them accessible across a patient's network. The removal of geographic restrictions is a big one that we've heard a lot about. And I think one of the areas, once Congress and we've seen Congress and states kind of look into things that they can do about telehealth, I think this is an area we'll start to see work from the very beginning. It's the originating site requirements, removing those, allowing folks to access those provider appointments from their home, instead of, in Medicare, the way it's now, folks would still have to travel to another clinic offsite. So they're still traveling to see their provider, but virtually seeing their provider who's still in another location. And of course, now with technology and access, how we all have that available at our home, it just doesn't make sense to force someone to do that anymore. So really making the home as an originating site is an important step. Interstate access, I think, is an area that we've heard a lot about during the pandemic for some of those rural communities or folks. I'm from Eastern North Carolina, but we are right at 20 minutes to the Virginia line. And so you can, for folks that live in those kind of conditions, like right at state lines, and maybe they're seeing a provider or specialist that's not located in their state, being able to access virtually those providers around telehealth services, I think, is something to consider. And then, of course, remote monitoring for those more chronic disease patients. And lastly, the last two, of course, certainly not not any less important, but just protecting patients and providers' legal rights, and of course, increasing the evidence base for telehealth. I think the pandemic has really given us a big pot of things to look at, and we're going to see more data. Medicare, CMS has put out data periodically for how much utilization of telehealth services has occurred during the pandemic, and I think we'll start to see that and maybe get that in some other health plans as well as we move forward. And that will help inform how well it's been going, maybe with some things that haven't worked well, and what we can do about it moving forward. There are, of course, several pieces of federal legislation that were introduced or around before the pandemic in previous Congresses, but there are some now that have been reintroduced in the 117th that kind of touch on some of these policy areas that we feel like are important for patient access moving forward. You have bills such as the TREAT Act, which would address that interstate telehealth access. It's been limited in that bill for just the period of the pandemic, but I think a more permanent solution would make a lot of sense. I know that there is a lot of conversation around kind of states' rights and what role state have in licensing providers. Those requirements are not always the same in each state, and that does affect how providers are able to offer those services in specific states. So there are ways, or there are things to think about if we're going to make this a more permanent policy with telehealth. But I think that there is a role for the federal government to play here. During the pandemic, some states decided to do that licensing reciprocity when others didn't. And I think that created some confusion or frustration for patients that maybe some folks in a certain state could access those providers out of state, others couldn't. And so really having just kind of a blanket approach, blanket rules and regulations that were easy and transparent and where everyone could be on the same page, I think is definitely something that a role that the federal government could play in making sure like interstate access remains after the pandemic. Of course, Crozier was talking about Representative Thompson and his bill that the Telehealth Caucus has been working on, the Connect for Health Act of 2021. So they've really updated it and taken into account some of the things that they've heard, during the pandemic, and would really focus on updating Medicare with telehealth services. And then, of course, Telehealth Modernization Act is another one that was introduced by Senator Tim Scott and Senator Schatz. So I think there are definitely federal legislative opportunities to make some of these things, Medicare being the biggest one. There's so many things in statute that even those flexibilities that were granted during COVID, those are time limited, and legislation is needed to make it able for those things to become permanent, such as the home as originating site and removal of some of those geographic restrictions. So I think federal legislation, especially around Medicare, is very important and will make a big difference in keeping that expanded access. But there's also other ways that telehealth can be influenced. Like I mentioned earlier, states have done their own laws. Nebraska, Dr. Snow is one of them, to make it around payment and reimbursement for asynchronous models for telehealth access. It allowed dermatologists, that was especially of interest to us, for their patients to send pictures of maybe their skin outbreaks and things to their provider virtually to get that care during the pandemic. So you've seen states really act on this as well. But back at the federal level, we've also seen things around telehealth through proposed rulemaking. So like the physician's fee schedule last go round really expanded the list of telehealth eligible services and made those permanent as we move forward. And, it's about that time again for us to do that rulemaking. So we'll continue to see like what's happening there and payment wise for providers to keep offering those services. And then also, looking at Congress, a lot of times nowadays bills don't move by themselves anymore. So looking for opportunities for things like this infrastructure package that we've all anxiously been waiting to see a final draft of. But in those discussions, broadband access for rural communities, that's something that would obviously have a positive impact on the future of telehealth access. So, there's areas in those infrastructure discussions that could be a positive for the patient community as well. And then maybe even during the appropriations process. So getting funding for grants or training for other government agencies like HRSA to really be able to help folks access those telehealth or give it, help them in the direction that they need to go to access their providers and better understand or utilize telehealth services. So, trying to do a nice job here of kind of wrapping up the points that everyone has made today. But I think really at the core of this, the cat is kind of out of the bag of folks having more access to care. And so how we do that in a way that's, beneficial for patients as we move forward, and making sure that the patient voice is really at the center of those discussions and considerations, I think is important. And thank you again, Eric and National Health Council, for letting me speak about this today.
Great, thank you, Hannah, and thank you to all of our speakers. We certainly heard a lot of common themes across the board from all of them, really geared towards ensuring that the patient perspective is included in telehealth policy. So I'm going to now ask all of our speakers if they can turn their cameras on. We do have a few minutes for some questions. Again, a reminder, if you haven't, any burning questions that you haven't posed yet, please do so in the Q&A box or in the chat. We do have a few in so far, so we'll start to get to those and see if we get any more as well. So the first one we have, and Hannah sort of alluded to this in talking about the need for more data on telehealth, and we certainly heard this from Crozer today as well. So I think the question is kind of alluding to the point that Crozer made. And the question says, are there any reports or studies of providers using telehealth in ways to provide better coordinated care, and through better coordination, have better outcomes and hopefully some potential savings compared, and looking at that to kind of offset some of the concerns we've heard about overutilization, fraud, waste, and abuse. So be curious if anybody is aware of any data about care coordination, or if not, even just anecdotal evidence might be helpful, and then we can look to see what there may be in terms of a more robust data set on that.
I don't have anything specific in this regard. I think that when I read this question, I've kind of been thinking about this for a little bit. If you look from my point of view, when you look at someone with rheumatoid arthritis, you compare outcomes from 1975 to today, the difference is we treat it more aggressively, we treat it earlier. And if you get patients access to care, I can use much less medicine in the long run. So I guess to maybe answer that question is, I don't have any specific data, but I can tell you get patients better access, you're going to have better outcomes in the long run. At least based on, this is rheumatoid arthritis. And I think that if you extrapolate that to pneumonia, you tell me what disease you want to extrapolate that to. I think in the long run, you're going to have better outcomes and you see less cost involved.
Eric, I think one of the reasons why we're not seeing a lot of publications out yet that have a lot of this descriptive information is because it's just a little bit too soon. So a lot of the work that's going to be done in this area is going to rely on a couple of things. One is that it's going to rely on claims data and EHR data. And very often those data sets don't become available until 6 to 12 months after the care has been delivered. And so, if we're looking at all of 2020 and the first 6 months of this year, that 18-month period, we may have data available to us for 2020. We probably don't have it available to us yet for 2021 when it comes to claims data and electronic medical record data. So as soon as those data sets open up and then become available, we're going to see a plethora of different studies being done on them. I think we're also going to see a lot of funders putting money toward those kinds of things. I think we already have started to see that. It's starting to happen, but the analysis isn't done yet. The other half of it that has to do with timing is that you've got to follow patients for a period of time to be able to see the benefit of the care that they got 6 months ago or a year ago. And it might be a little bit too soon for many diseases for us to know whether or not there are benefits, just because it's part of, we have to follow the natural history of the disease to see if that's changed at all or if we've had an impact on that. And it's probably a little too soon to see some of that. I would say within the next year or so, we're going to see many of these studies, especially with a lot of the funding sources directing their research funding toward specifically these kinds of studies.
Yeah, and I think the one question will be is, what can we extrapolate from the pandemic utilization compared to post-pandemic when we have more of a mix of in-person. So it'll be
Exactly.
interesting to see people who are smarter than I am are able to figure out how to actually extrapolate that data. So I have another question. This was asked early on, and I think we've sort of addressed it, but we'll open it up if people want to expand a little bit more. The question is, what can be done for those who want or need telemedicine, but don't have good broadband access? I think we've talked about audio only, but I'd be curious if anybody else wants to kind of put a finer point on this one.
No, I think that audio only does serve a purpose for those situations, especially as we move forward, and making sure that that's around and how to address that in a way that works for everyone involved from a payment perspective, but also patient access, I think, is important. And then some of these other discussions happening around rural broadband access, if that does move forward, I think we'll see that will have a big impact on patient access to these telehealth services, but just also the types of technologies that are allowed to be used. If you're required to use a specific platform by your provider or specialist, that may be difficult for some of those folks with the worst broadband. So that all comes into play too, is are they offering only one modality of access to the telehealth service, or do you have options depending on what type of internet access you have available to you?
Great. So one final question, and I want to pose this to Dr. Snow and to Sharon as well. One of the things that we've been hearing from folks in Congress is we know oftentimes they work on deadlines, and we know that a lot of these flexibilities are still available through the end of the public health emergency, but have been hearing from some providers and from some patients about the need to address it sooner rather than later. So I'd be kind of curious to know, first Dr. Snow and then Sharon, love to have you kind of bring us home about the need for urgency and speed here. So I'll turn it over to the two of you to address that.
Thank you. Yeah, that's a great question. Right now in my clinic, I am booking out for return patients 3 months, new patients about 4 months. So, trying to get those appointments on the books and trying to get it to a spot that flows with the workday is really important. And so, for me, I'm living 3 to 6 months in advance as far as new, appointments. So I think that just from a logistical standpoint, I think that that's important. I also think that when you're looking at budgeting, you're looking at the bottom line, how you're going to approach things. There's many levels to, before you see a patient, there are many levels that decisions that need to be made. So I think that from those two standpoints, I think it's really important that we know where we're going to be in 2022. We know where we're going to be when the PHE ends.
So as a patient, one of the things, actually the thing that's most important is finding the right doctor. And I've seen with many of my fellow pemphigus patients that some have spent up to 2 years finding the right doctor. They keep going from doctor to doctor, no one knows what it is. And by the time they're diagnosed, it's so complicated and so expensive that they are just beside themselves. And so I think televisit is a way for people to find a doctor. If they don't have a blistering doctor specialist in their state, like I do, or somewhere nearby, that they can find that doctor. And the International Pemphigus and Pemphigoid Foundation is great, like pointing us in the right direction for doctors. But for some people, it's just not possible financially to make that trip, or for other reasons. And so I see that as the most important issue, is finding the right doctor is it. And, I feel like I found the right doctor and now I can't have that doctor anymore. So it's disheartening. And that's not to say the doctors aren't good here in Vermont. It's just that it's not their specialty. And right now I'm in remission, but if I start becoming symptomatic again, then it gets complicated. So I guess that would be my 2 cents.
Great. Thank you, Sharon. Again, really appreciate you being here. It's always good for us to remember why we're doing this, as we have some of these really technical conversations about CMS payment policies and broadband access and all these things. But at the end of the day, we really do want to do what we can to make sure that Sharon's able to continue seeing the doctor that she wants to see and needs to be seeing. So thank you. And thank you again to all of our speakers. Thank you for those of you who tuned in and those who posed questions. This concludes our event. We will make the video recording available on our website. So for those of you who are still on, we'll make sure we send the link out if you want to share with any of your colleagues or anyone that you, any relationships you have on Capitol Hill, that would be great. So thank you all. Hope you all have a wonderful rest of the day and rest of the week, and look forward to continuing this conversation.